So welcome to Penn State College of Medicine's COVID-19 session on holiday safety and precautions. This session is hosted by our Division of General Internal Medicine. We're delighted to have you join us for today's session and hope that we can engage you all in discussion that might address some of your COVID-19 questions or concerns. My name is Ellie, and I'll be facilitating today's session. So a few announcements before we begin. We'd love to see your faces, so if you're able to share video, please do so. Also, stay muted unless you're speaking. To do this, you can dial *6 on your telephone, or you can click the mic icon that's on the bottom left of your computer screen or your Zoom screen. We realize that question and answer time is very important to you, and we're trying to categorize and address as many questions as possible here, but we'll follow up with any open items after the session. Please note that no personally identifiable information is allowed during the session if discussing specific medical cases. In the spirit of all teach, all learn, we will be on a first name basis during the sessions, and this session, as I mentioned, is being recorded. We'd like to start off with an interactive and expert-led presentation to be followed up by a question and answer period. However, please feel free to ask any questions in the chat function as you have them. My teammate Erica Francis, Erica Wave, will be moderating the chat, and we'll get these questions to our presenters at the completion of the lecture. You can message her privately if you'd prefer to ask your question anonymously. A special thank you to Drs. Jennifer Krasnowski and Cynthia Schwang for organizing this opportunity, and to our presenters for offering their time and expertise. And with that, I'm going to turn things over to our presenters who can introduce themselves. We'll start with Dr. Jonathan Nunez.
Good morning, everybody. I go by JJ Nunez. I never like to be called Doctor or Jonathan, is reserved for my grandmother, but feel free to call me JJ. I am very pleasant to have joined Penn State about 15 months ago, and I work under the Division of Internal Medicine. So I get to work with these awesome colleagues that I'm talking with. And then also under infectious disease during this time with COVID, I think we all have been super popular. So should I go on, or should I let everyone else introduce themselves first?
Yeah, let's have everybody introduce themselves, the speakers. So Rachel Casas, Dr. Rachel Casas.
Hi, everyone. I'm Rachel. So nice to see all of your faces today. I'm also in the Division of General Internal Medicine, and I do primary care and women's health clinically. And I've been at Penn State for a little over 3 years now.
And finally, Dr. Paul Haidet.
Hello, I'm Paul. I also am a general internist, primary care physician. I've been at Penn State since 2009, and before that actually practiced at the Houston VA in Houston, Texas for 11 years.
Great, thank you so much. So with that, I'm going to start the brief lecture and share my screen for slides. So I'll kind of take your cues, speakers, and I'll advance the slides for you. And here we go.
So thank you. So the COVID-19 pandemic has been super stressful and isolating for many. I think for the last few weeks, the messaging from public health officials have been that the safest way to celebrate the holidays is to celebrate virtually or with members of your own household. As I mentioned to friends, patients, and even family members, in-person gatherings that bring together family members or friends from different households pose varying levels of risk, especially when COVID is in the surrounding areas. So how are we doing, and how are things going in Pennsylvania? So as we look and review COVID-19 data from our state, I would like to highlight the figure on the left, which is reporting the daily COVID-19 cases. On the bottom, we have months, and on the side is number of cases. The blue line is representing cases. As I highlighted it with a yellow oval, what we can see is the dramatic increase of reported cases that have been occurring since late September. Next slide. So this is provided from the State Health Department website, which provides a COVID-19 dashboard. And the info is updated every day at noon, disclosing the number of confirmed cases, probable cases, test results, which can provide some information even by zip code. What I want to highlight is that we are seeing COVID everywhere. The counties are color coded. The darker shades of red signifies that the number of cases over 100,000. So again, I stress, although we have been physically distancing and taking measures since early this year, as we have entered the fall, the number of cases has risen dramatically and is present throughout the state. So we should not ease up on measures now. Next slide. Again, pulling a figure from the State Health Department website, we see how the number of cases have been increasing dramatically. I find this figure easier to see and view and highlight some of the changes that occurred in the epidemiology of the disease compared to when we first were able to test for the disease and began managing the disease. Highlighted in the yellow oval is an increasing number of cases. As we have an increasing number of cases, I do get concerned in protecting our elderly patients or patients with certain medical conditions that could cause severe disease, preventing the strain on healthcare system as we provide and try to provide excellent care for these patients with severe disease and preventing further deaths. Next slide. So where are we now with testing results? As more testing has and is being done, the number of positive test results have been steadily increasing as COVID-19 is in our surrounding area. As of data from earlier this week, the positive test rate has averaged nearly 11%. When we compare to other counties, so looking at Dauphin County, we're nearly 11%, Philadelphia about 12%, and Allegheny County about 8.1%. So what I want to highlight is that COVID is in our area, and although some of us may not have had it or known others who've had it, it's not time to drop our guard, especially as we consider traveling. I quote one of my amazing colleagues, Dr. Buchberger, as I think for the safety of everyone, especially our older loved ones and people who have underlying conditions at risk for complications for COVID, sharing a meal virtually may be the safest. So I'll move on to, I think, Paul.
So JJ just shared with us the epidemiological data, and it's scary. The bottom line is that COVID is increasing and increasing rapidly so where we live. What I'd like to do is take us to what do we do with that information? And I'm going to grossly oversimplify things by saying that COVID primarily spreads through the air. So the virus particles get into the air, and then you come into contact with virus particles, and if enough virus particles get breathed in, you get COVID. And so knowing that that's one of the primary ways that COVID spreads, there are 4 questions you can ask before you do anything to ask how risky is it going to be in terms of catching COVID. And those 4 questions are these. How close will you be to other people? If you come into contact with a person with COVID, if you are closer to them, there are more virus particles in the air around them than if you are farther away. So the closer you get, the higher your chances of getting COVID. How many people will be there? If you are in a room with 20 people, the chances of one of those people having COVID is higher than if you are in a room with 1 person. And I give the side question of where are those people coming from? If you are in a room with 5 family members who you've been living with for the last 3 months and nobody's been going out of the house or everybody's been wearing masks and be safe, the chances of coming into contact with COVID are lower than if you're in a room with 5 people who have come from 5 different areas. In other words, everybody you come into contact with is not just that person, but everybody else they have come into contact with. So if you have a kid who's been going to school and interacting with all the other kids in the schools, coming into contact with that child is like coming into contact with the entire school. How long will you be in the space? The longer you are near somebody who is infected with COVID, the more particles you can potentially breathe in, the more your chances of getting COVID. That gets blunted if either you or they are wearing a mask, and can get blunted quite a bit. How enclosed is the space? If you are outdoors in a park and the wind is blowing and you walk past a person with COVID, the particles are going to get dispersed by the wind and the area, as opposed to being in a small, enclosed, non-ventilated space. Now, I will just say that most single-family homes do not have high turnover ventilation, so the ventilation is not good. And tomorrow on Thanksgiving, it's supposed to rain, so most of us are going to be indoors. Okay, so that's the spiel. Next slide, please. So let's all analyze this. I'm going to read the STEM, and then I would love to hear people say it. And here's the determination. Here's a scenario, and what you're trying to determine is this low risk, medium risk, or high risk? Using those questions. Okay, my family and I are planning to do Thanksgiving together at my sister's house. There will be my sister and her husband and their 3 kids from York, my wife and me and our 4 kids from Hershey, my brother and his wife and their 2 kids from Lancaster, and our mother and father from Wyomissing. We'll be doing Thanksgiving at my sister's house in York. The kids are really looking forward to being with their cousins. We plan to wash our hands lots to be safe with COVID. Now you tell me. Now let's stop stop the share. Throw into the chat box, low, medium, or high risk. What is your determination? We've got tons of highs, high, insanely high. Would somebody like to comment on why they think the risk is high?
Please feel free to unmute.
Yep.
Too many people in a small area, not to mention it goes against the governor's guidelines for 10 people.
Right, so it's against the governor's guidelines. It's 17 people in one house. What else is giving risk to this scenario?
The geographic dispersal.
Right, so we've got people coming from 4 different areas, and presumably those kids have been in schools. So you've got whole schools from 4 different areas coming together in terms of representation of contacts. Absolutely. What else?
She didn't mention anything about wearing masks.
And even if you're wearing masks, you got to eat dinner. People are going to take the masks down for dinner, which is going to take at least a half hour. What else?
Well, it violates the four arrests that you just went over, every one of them.
Yep. Ellie, why don't you share the slide for a minute? And go to the next slide. So here we go. How close will you be to other people? Probably very close. It'll be hard not to hug and stay 6 feet apart in a single family home with that amount of people. How many people will be there? 17 people from 4 different counties, all with rapidly rising infection rates. How long will you be in the space? And will you have a mask on the whole time? You'll probably be in the space for several hours at least, with at the very least no mask wearing during dinner. And how enclosed is the space? Very enclosed in a single family home with 17 people with low turnover ventilation. The bottom line is this is high risk. Okay, can you unshare for just a sec? The last thing I want to lead you with is, for the last month, I have been closing every one of my visits with patients asking, what are your Thanksgiving plans? And I will tell you, I have heard this story multiple times. I have heard multiple of my patients saying, oh, well, we're going to be careful this year. We usually have 30 people, but we're only going to have 15. And I've heard from my elderly patients, I've heard a number of them say, well, my daughter wants to have us over to her house and I don't want to go. And she's really angry at me for not coming. Can you give me some advice? To which I say, I will write you a note and you can give it to your daughter and you can place all the blame on me, but you can tell them I right now am forbidding you from going to your daughter's house because the risk is high. So these 4 questions you can use with whatever you're going to do. Going to the grocery store, medium-ish risk, and it's something you have to do. If you wear the mask and limit the amount of time you're in the store and stay away from other people in the store, you can keep the risk manageable. Going for a walk out in the park, pretty low risk unless there's like a demonstration going on in the park. Going to church on Sunday, high risk. Lots of people, hard to stay far apart, gonna be in the space for 90 minutes. And most churches don't have great ventilation, although some have pretty big open spaces. So the 4 questions can give you an idea of how risky something's gonna be. And with that, I'll turn it over to Rachel, who's gonna talk about getting tested and what happens if you start having symptoms.
Thank you, Paul. So now you all know an approach to thinking about your risk if you're going to be traveling. I want to delve a little bit into that and some other situations where you might consider getting COVID testing. So I think we're all pretty familiar with the symptoms of COVID at this point. Ellie, would you mind clicking on the hyperlink at the bottom for the CDC page? The one that's in purple. Thank you. All right, so I put this up here just in case you need a little bit of a reminder. The cool thing about this page is that it has this coronavirus self-checker, and you can put in any symptoms you're having, any risk factors you have, and it can help you decide if you need testing or if you need to get some medical care. And then it does also list the symptoms to watch out for. All right, Ellie, if you wouldn't mind returning to the slides, please. Thank you. Okay, so that's one situation if you have symptoms. The other situation to consider testing is if you've had close exposure to someone who you know has COVID. And the way the CDC defines that is if you're within 6 feet of someone with COVID for 15 minutes or more. Another is if you're planning to get a procedure. So this can be if you're going to have surgery, if you're going to have something like a colonoscopy. Right now, there is screening done for everyone who's having those sorts of procedures. And then lastly, travel, which is what we've been really focusing on this presentation. As you all very likely know right now, there is the guidance from our state government about getting testing within 72 hours if you are crossing state lines in and out of Pennsylvania. Next slide, please. So there's a lot of options for getting testing for COVID. So how do we figure out which is the best option? I would say the first place I'd recommend checking would be if you have a primary care physician or provider, giving their office a call and just seeing what options they are offering for you, their patients. And if you don't have a primary care physician or provider, there are still a number of different options. You can go to any of our local urgent cares. You can make an appointment at the pharmacies in the area. So CVS, Rite Aid are all offering testing. From what I've heard, there is a pretty long wait to get an appointment right now, unfortunately, because of the surge we're seeing, as JJ highlighted. Another option could be to utilize the Penn State Health on-demand app. So if you go to your internet browser, and I know you're all on here, so you're all internet savvy, and you put in on-demand app or do this through your phone, you can download this app and make an appointment with a provider who will see how you're doing and talk to you about if you need testing or additional treatment. So obviously if you're really sick, if you're having trouble breathing, if you're having chest pain, we are going to want you to be seen urgently in the emergency department, and they would do your testing at that location. And then the last testing option I wanted to mention is Vault. So, and if you Google Vault COVID testing, this will pop right up. So this is a company that is offering at-home testing. Pretty much what happens is they send you a kit and you do a swab in your mouth, and then you send it back and they test it for you. So overall, insurance coverage for these tests has been good if you are symptomatic or you have symptoms, or if you have an exposure. For the purposes of travel, it's been a bit more unpredictable. So there is a chance you could have to pay out of pocket for a test that's done for travel purposes. And for example, the Vault testing is $120. So these are, if you are a patient at Penn State Health or you use the on-demand option, these are our testing sites. We have 3 of them over at the Hershey campus, Mount Nittany, and St. Joseph. They are only open during the week. So if you're needing testing after hours or on the weekend, you would need to use one of the other options I was just mentioning. Next slide, please. So I get this question a lot. What should I do after testing? I'd say the really key thing here is to stay at home. So even if you're pretty sure you don't have COVID and your test is still pending, still really good idea to stay at home. The other thing that's important is to keep track of your symptoms and definitely to let your doctor know if you're feeling worse. Staying away from others in your home can be challenging. The recommendation is that if you can be in your own bedroom, sleep apart from others, have your own bathroom, that is best, but there's not always that space available. So we recognize that's a challenging thing to do. Other things are to avoid sharing personal items, washing your hands, covering coughs and sneezes, cleaning common surfaces daily, and of course, wearing a mask. Next slide, please. So what happens if I test positive? So you can be around others after 10 days, if it's been 10 days since you had symptoms when they first appeared, if it's been 24 hours and you don't have a fever, and other symptoms of COVID are improving. And anyone who's had close contact with someone who has COVID should stay at home for 14 days after their last exposure. Next slide, please. And then what if I test negative? So if you've had a close exposure to someone with COVID, it's still recommended that you stay home, isolate for the full 14 days, even if you test negative. And then for travel, what if I test negative? A question I've had a lot from my patients is it safe for me to travel to see my family if I have a negative test within a few days of when I want to travel? And I think as Paul was discussing, this is a really tough question to answer. And the main reason is because it's possible to get tested soon after you get exposed to someone with COVID, and you could have a negative test and you could have no symptoms and then go on to spread COVID to your loved ones. So it's definitely a challenging situation and a challenging decision that we're all facing here. Next slide, please. So just to briefly summarize everything we've addressed so far, for JJ's section, the cases of COVID nationally and particularly in our region are on the upswing. We are experiencing a surge right now. As Paul was mentioning, carefully consider the risks of situations where you are with other people, those 4 questions. If you have any symptoms concerning for COVID, call your doctor or another testing option in your community. Stay home and away from others if you've been tested for COVID or if you test positive for COVID. Next slide, please. And these are just some websites for you all to take a look at. This is our coronavirus updates page from Penn State Health, and then also the CDC website. Thanks so much for your attention.
Thank you all so much. So we have about 30 minutes and you have access to some really brilliant medical professionals in this Zoom room. So if you have any questions, please feel free to unmute yourself or put them in the chat box. I do see that there are 2 questions there, and then I'll touch base with Erica to see if there were any sent to her privately. But one of the questions we have is from Roderick. Will room air purifiers help?
So I'll take a first stab at this one, and I'll ask my colleagues to join in. And I'm going to guess this may not be a super definitive answer. Here's what I know. They won't hurt, but realize that the filter that's in a room air purifier matters, that some filters will actually filter virus particles and others that won't. The other thing that I've been looking into is, the filter that's on your furnace in your house, you can buy filters, they're more expensive, but filters that filter virus particles. Now, again, when it comes to HVAC systems, it's all about how frequent the turnover is of the air in the room. So those little room air purifiers that sit in a corner, it's unlikely that they turn over the air in the room very quickly. So while I think they won't hurt, I'm not sure that they help very much. That being said, I have, at my own house, I have gone and bought the filters for the furnace that have the small enough pore size that filter virus particles. Again, thinking it's not going to hurt things, and maybe it might help a little bit. If it helps, it's going to help a little bit, not a ton.
I would echo that with Bob. This is JJ. I think a couple of things is one is how frequency the air is actually turned over. And then two, I'm always a big fan of like data. So again, there's not much data on this stuff whatsoever. And one thing I would mention is that usually when you're taking flights, there's supposed to be purifiers and high ventilation. Even during early on in the epidemic, there were still cases that were traced back that were found during flights. Now, you can argue those were without masks, but I would still say I would use them with caution.
Next question is from Thomas. Is there a difference between isolation and quarantine?
I can take a stab at this one, or unless you do, Rachel. So really, the difference is just on the definition. When we think of isolation and prior illnesses, we usually think of people who've actually been sick. The practice of what they're doing is the same. Quarantine is usually meant to reserve for term for people who might have been exposed. So you're keeping a closer eye on them to see if they actually develop symptoms. As for the practice of what you're doing while you're isolated versus quarantine may be the same. The only difference I would say at the moment though is that quarantine, the days are a little bit longer, right? We're saying 14 days. And I'll comment on one part and then I'll mute myself. Right now, we're still saying 14 days. I know there's a lot of press stuff saying that CDC may make recommendation changes, but those recommendation changes haven't been presented yet. And we're also using and working with what the Department of Public Health is giving us for guidelines in the state of Pennsylvania.
Great. We have a question from Stephen. If family locally or from another state has been isolating for 14 days just for safety, not for close contact, would that be considered relatively safe to see them or have them visit? What does the group think before we have the experts weigh
That's
in?
a good idea.
Anyone? I'm really good at pausing. I've learned from the best.
Well, it's definitely a lower risk, but I don't know how safe it is.
Any other thoughts from the group?
I agree. I think it's a lower risk, but I don't think it's completely safe.
So I would say, again, we're thinking probabilistically here. Nothing is completely safe. And nothing's 100% either. And the question is, how risky is this? And I guess I would answer the question with a question, which is, how much do you trust your family? Do you trust that they have truly been isolated for the 14 days? Have the kids been in school? Have they not been? Where have those people been? Because remember, everybody those people have been in contact with, you are potentially bringing into contact with you. I will say that with very few exceptions, there have been no family in my home since March. My brother comes over and we stand out on the front lawn and have a conversation 6 feet apart. You know, it's just, you know, your home is your safe space. Now it becomes a different thing if somebody gets COVID in your home. What do you do within the home then? But it comes down to how much do you trust your family. If they truly have been isolating and truly have been 14 days and nobody is having any symptoms and nobody's been in contact or minimal contact, then the risk is going to be lower. Yes.
A question from Ashley. Do COVID positive patients get retested until they test negative?
It's a good question. So in general, we do not routinely retest people who've tested positive for COVID. The main reason being is that once you have COVID, you can still have a positive test for it's up to months, up to 3 months after you've had that test. So it doesn't mean you're contagious. It means that the test is still positive. So it doesn't usually change our recommendations for people, which are you should remain at home for at least 10 days from the onset of your symptoms. So it is not a situation where we routinely retest people.
A question from Thomas. Do you recommend a HEPA filter on home HVAC and keep the air circulating constantly?
So I'll go and then I'll maybe throw it to JJ. Again, precious little data. It can't hurt to put a HEPA filter on your home furnace. If it's the filter that filters out virus particles, and if you go to Home Depot, you can see the grades of the filter, and they talk about whether they filter bacteria and viruses. Running the fan constantly is interesting. That will increase the turnover of the air in the home. These days when it's cold and the fan is kicking up fairly frequently, I think we're talking incremental gains here. So once again, I'm in the it can't hurt category, but I'm not sure how much it helps.
I would echo what you said, Paul. I think, again, one, limited data. I think overall, when you review, even going through a house, not all areas are heavily ventilated. People are traveling throughout. I think most of the stuff that we learned also from outbreaks within churches, outbreaks within certain restaurants. I always say, like you mentioned, it couldn't hurt, but I wouldn't necessarily recommend that as what's going to keep people safe.
There's a belief that a vaccine is a cure-all. Do you foresee the mask wearing and precautions extending through 2021?
I can take a stab and people can add on. I think one of the big things I would mention is, it's amazing to see the global response overall and development of a vaccine that's been so quick. I think one of the big things I would mention is that I do think there's light at the end of the tunnel of this pandemic. And the fact that so far the efficacy of many of these vaccines are showing to be super effective. I think one of the limitations, even as we're planning out and rolling out new treatment modalities within our hospital system, it takes planning. So although the vaccine is being developed, it takes planning to actually give it to the patients that necessarily need it and the healthcare workers that need it. So I don't think it's going to be offered as quickly and everyone covered. I think it's going to come in waves and stages. But overall, some may be coming even in mid-December, which is exciting. The one thing I would say is that some of the precautions that we see now probably will carry over to 2021. And I do mention that we've never had to do this before. I know overall even from our experiences, we put our guard down mostly because, maybe we haven't been exposed or known someone that has been exposed or someone that had it. but the disease is there. So I do think until the foreseeable future, we'll still be using some of these precautions. And I hate to refer to it as socially distancing, because I think one of my colleagues have mentioned it multiple times in GI, general internal medicine. Yes, we're maybe physically distancing, but it doesn't mean we have to be socially distant.
So we have a question from Pam. The Department of Health contact stated that if COVID positive mild case and recovered is considered immune for at least 3 months and not contagious. Do you concur with that? Is there risk of a small gathering? Do you still wear masks the whole time?
I think that there's a few things to consider in this question. So kind of the risk for that person who did have COVID. So the likelihood of that person who had COVID getting it again within that time frame is relatively small. There have been instances, not many, but of people being reinfected with COVID, but I believe the time frame is a bit longer than that. And JJ, you can correct me if I'm wrong here. But I think that, at least for me personally, the recommendations I would have if that person were in a group would be the same in terms of physically distancing from people and mask wearing. Not because I think that they necessarily would get COVID, but because of the other people that they are around, where their risk would still be the same.
I would echo that. I mean, I think one of the big things I would tell everybody is we are making decisions on a disease that probably we know less than 12 to 14 months. So a lot of things can change. And actually, I do describe it as that every time you talk to us as healthcare providers, I can understand patients' frustration. Every time I talk to you, it's something different. I totally get it. It's like drinking out of a fire hose, the amount of data that comes at us. But what I highlight is there has been reinfection, and it's been documented. And when you strain it, it's a different virus. So I would tell people to still take that caution, and especially because we're going into flu season. So granted, we haven't seen as much influenza in the area. We know it's coming. And right now, there are other respiratory illnesses that we don't necessarily always check for, which makes it very hard to really decide if someone has COVID or non-COVID during a time where there would be other viral respiratory illnesses that we would see this year. So I say even wearing a mask will protect from that stuff too.
Great suggestion. Anastasia says no one, and she means no one, in her townhome community practices social distancing, and they don't wear masks. How risky is it if I open my upstairs windows for an hour during the day?
So I'll take a first stab, but I want to hear from JJ or Rachel after. So we're talking about people walking around outside without masks. And we're assuming the average day with sort of the average kind of breeze going around. Virus particles are going to dissipate pretty far apart outside, which is going to lower the amount of virus particles if you're outside that you come into contact with. Realizing that you're inside and you're opening a window, the question becomes how many of those virus particles would come through the window, assuming there's airflow through and you have 2 windows open, that the airflow is moving through your house. I would consider that to be a relatively low risk situation. It'd be similar to taking a walk in the park where you can say socially distanced, you are outside. The time that you're in close proximity with other people is low. Here, that time is 0 because you're not in close proximity with anybody, and the window's on the 2nd floor. So that sounds pretty low-ish risk to me. JJ, what are your thoughts? JJ, Rachel, what do you think?
I would echo, I would concur. I mean, I think one of the big things I would mention compared to other activities, I would consider that to be much lower risk. And it's the same thing as when I go running outside. I may not always wear a mask as long as I'm physically distanced. So I think it's very hard to run with a mask. It's hard to wear a mask all day, I agree, but it's hard to run with a mask. So I would agree with you, Paul.
And we have a final question, at least in the public chat. Our church is trying to plan for Christmas Eve. What are your thoughts on 15-minute outdoor services with distance masks? Knowing it's hard to always enforce that, but people did a pretty good job this summer. Would you consider it low, medium, or high risk?
So I actually have a personal story about that one, because our minister has called me several times saying, can I open the church yet? And I'm like, well, you're gonna have to make your own decision on that one. But here's the deal. You know, I go to a church where probably the average age of our congregation is well into their 60s and pushing 70. So we're relatively high risk for COVID being bad population. I think in the church is high risk, no doubt. You know, you're going to be there 60 minutes, hard for people to keep apart. Ventilation's not good, and you're in the space for a long time. So it gets high on all the four questions. What I talked about with my minister this summer was, if you wanted to try something, what you could try is go into that big field above our church, which is outside, spray paint circles on the ground so that people know where to stand, and shorten the services. And our assessment at the time was that takes a high risk situation to a moderate risk situation, because you'll probably still be an hour in the space and there might be a lot of people. So it gets 2 out of the 4. I like the idea of doing the 15-minute thing. The question becomes whether how many of your people would come to that, and how long it would be. If it truly was 15 minutes and then people left and didn't mill about, and if truly they stayed social distanced with some kind of job aid, you still have one of the criteria. There's going to be a lot of people there. And the question is, are they going to be wearing masks? So there's still one of the positives. So it's not low risk. It could be low, moderate risk, but that depends on the people staying apart, keeping the mask on, and leaving after 15 minutes. And if he's going to batch them and do 15-minute services, then you got to leave some time in between the services for any potential virus particles to dissipate in the air. And all of this is predicated on Christmas Eve it not be raining. So yes, that is definitely lower risk than going into the church. Is it devoid of risk? Absolutely not. There is going to be some risk there.
A question from David. As a practical matter, if someone finds themselves in a situation where they need to travel out of Pennsylvania, not over the Thanksgiving holiday, what is the best way to arrange for testing?
So good question. So as of right now, unfortunately, because of the amount of testing that's being requested for people who have symptoms, at Penn State, we are not currently doing tests for people who are traveling. So the best options would be one of the others that I mentioned. So you could go through an urgent care, you could go through the pharmacy, you could get the vault testing, which is the one that's the mail order test. With just remembering that you could end up having to pay for the cost of that test.
Just a couple of things to add to that, Rachel, too, is that I think one of the big things is, in a perfect world, we would offer testing to everyone. I think one of the logistical issues that has come up is that, you know, as there's a lot of testing results, there's a lot of delays. So during the initial part, some of these test results were taking almost as close to 7 to 10 days back in March, April, and May. That improved to about 24 to 48 hours. And now we're starting to see some of that delay again for these outpatient testing, which I think makes it very limited. One of the things I've been mentioning to make travel a little bit easier, I do tell people to kind of start quarantining prior going, And if you're going to go visit someone, they also quarantine before you get there to kind of help limit that. Because I think the concern I get a lot is that with these test results, we feel super immune going, yeah, I am negative, meaning that in my world, usually negative is a good thing in infectious disease. So, but I've had the test result become back positive when they've had developed symptoms.
That's great. So we have another question for the dispensing of vaccines. Where will it be determined who gets it first if a patient has some of the indicators of need, diabetes, high blood pressure, autoimmune concern, but otherwise is healthy? Would they be on the list for getting the vaccine?
Would you guys mind if I answer this question, Rachel and Paul? Okay, so I think one of the big things I would say is each state has their own plan that they had to submit to the Centers for Disease Control for how to dispense vaccines. Each state plan is drastically different. I think one of the big things as we're starting to plan this, and I'm not as involved in this part for the ethical stuff within our healthcare system, but I can see it as we discuss other modalities of medications to offer patients that they're coming, is that one of the big things is the allotment that we're getting. It's not going to be an endless supply for everyone within our state. So a lot of the different states are kind of prioritizing those who would be considered higher risk. So one of the things would probably be, hey, should we be focusing on healthcare providers that are actually providing care for patients that are COVID positive? Because, or any part of anyone that's involved in their care, because they're probably the highest risk at the moment. And we need to keep them healthy and our hospital system working so that we can continue to take care of patients in the community. 2 is probably going to focus on patients that have higher underlying conditions. So when we kind of stratify, we may have to stratify on patients who may be considered to be in that spectrum of, if they were to develop COVID, would they fall under having complications from COVID? On top of that, it depends on the vaccine that we have, because the storage issues are going to be one of the big things for us too. And if it's going to be 1 shot versus 2. So I think as we're learning more data about the different vaccines, that will help us plan. The third aspect to that is once you have it, we still have to give it to you, get it to the community. So I think a lot of the logistical planning of how to actually do that, even when we give our own flu shot, right? So we plan for that. Usually we have nursing, we have supplies, we make sure that it's kept in the right place and stored correctly so that we provide it. I think there's going to still be that plan to come.
Thank you, JJ. So we have some questions here about testing, and I'm going to kind of bulk them into one. So there's some questions on, how many different types of testing are there, and how accurate are each of those types of testing?
I can start this one and then hopefully someone else can jump in. So there's kind of 2 different, I think of it as being 2 different pools of testing. So one type of test looks at the actual parts of the virus. So it looks at if there's parts of the virus in your blood, and another one looks at if your body has responded to the virus that's in your blood. So that's the PCR testing, which is most of our nasal swabs that we're doing. And then the one that looks at your body's response is the antibody testing. So in this case, we're pretty much focusing on the testing for the actual virus, which is the nose swab, or I left out one, the one with the saliva, which is the vault, also is looking at what we call an antigen or a protein in your blood in response to the virus. So those are kind of grouped together in ways to tell if you have the virus that's ongoing and acute. And then the antibody testing is kind of after you've been infected. Kind of broad strokes, those acute tests are considered to be they're reasonably accurate. I'll let JJ or Paul kind of comment a bit more on the specifics. The antibody test, it's a little bit of a situation where we aren't quite sure what to do with it because it's unclear if everyone who has COVID, how long their antibodies are going to be there, if they're going to test positive for them or not. And then also really what to do with that information once you have it. So I'll stop talking and hand it off to someone else.
I would describe the testing at some of the aspects as kind of like how I describe it to my patients, like the wild, wild west. There's so many different tests that's being offered. We don't know. They're not all super validated. There's no real great gold standard to compare when we're talking about like the sensitivity and specificity. Each test has its fault. So I would mention even from the testing that we provide, sometimes the estimates have been anywhere from like 70 to 80. So if someone's really considered to be high risk, they have a disease that's really kind of close to it, sometimes we may end up doing multiple testing. So this is times where I might keep patients in the hospital. When they're in the hospital, I might do multiple tests. Even if the test result comes back negative, I might go, you know what, that disease is too close to really sound like COVID. We may just keep them isolated when they're actually being treated here. Antibody testing, no one really knows. And I think the other thing is no one really knows what to do the test result. So there's some, with other antibody testings for other infectious diseases, there's cross-reactivity. So is it, if the test result's positive, is it cross-reacting to some other type of coronavirus that might have been exposed? We don't necessarily know. And I think the other big thing to mention is time of test. So if your test too early, when you get exposed to something, that's called the incubation time. When the virus is replicating, it actually has to incubate to actually make that test result positive. So it has to replicate in the body. So like, that's another big thing I mentioned, the issues with testing is that you really have to have an idea of when you were exposed, and maybe that first test is gonna be negative, but that subsequent one may be positive.
And I would just add, bottom line, there's no such thing as a perfect test. So there's no such thing as a yes or no answer. It's like weather prediction. If there's a 40% chance of rain today, are you going to take an umbrella or not? This is what we're talking about. If somebody tests negative, are you going to have Thanksgiving dinner with them or not? What is the percent chance that they have it? If they test negative, the percent chance is lower, but it doesn't ever get to zero.
Great information. I'm going to put Dr. Cynthia Chuang on the spot here for this next question. She's chief of our Division of General Internal Medicine, and I know she gives these updates frequently to our group internally. There's a question from Stephen. How critical is the situation locally? For instance, are hospital beds running low on or ICU beds or medicine or equipment?
Thanks, Ellie. First, I want to say thank you to my colleagues. I'm so grateful that we're having this session, and I'm so grateful for our community for being here. Yes, we are seeing more cases in the community, and it is certainly affecting our hospital capacity. We are easily seeing about twice as many patients hospitalized now as we did in the spring. So it is more dire now than it was in the spring. In the hospital, we've converted units over to care for COVID patients. So we have COVID units, and I believe we have 4 COVID units that are completely full right now. So it is becoming a dire situation. We need to keep the hospital staff, our nurses and our physicians healthy to be taking care of everyone. And so I think that's one of the reasons why we feel it's so important to keep the cases down as much as possible, because we don't want to get to a point, as some of our colleagues have nationally, to not be able to provide the best care that they can. We have colleagues in other parts of the country right now where pediatricians are taking care of their adult hospitalized COVID patients because they've run out of resources. In terms of, our group has also been responsible for calling outpatients who have positive test results. And we are calling 50, 60 or more people a day, non-employees, but people in the community who've gotten their tests done here at Penn State to tell them that their test results are positive. And so the number is getting overwhelming. And quite frankly, we will call people, most of them are home isolating. Rachel told us the recommendations that she gives when she sends someone for a test and tells them to isolate. but not all of them are. Sometimes we call someone with their positive test result and they're at work or they're at the grocery store. And so I say that not to be alarming, but just to say that unfortunately not everyone's following the directions that Rachel gives. And there are folks out in the community that we see in the grocery store and everywhere else who are COVID positive. And so we really need to be very careful.
Can I just add to that a little bit? I get a sense that just from the questions you're asking here, that the community here on this call is a little bit of the choir. And I want to make an appeal to you to talk with your friends, to use your own spheres of influence. Now is the time for us as citizens to step up and help our community. What Dr. Fauci said on what I heard him say on the weekend is exactly right. You heard Dr. Chuang break it down. I'm not worried about this week. I know our hospital has the capacity for that. But if people put into play the plans that they're talking about for Thanksgiving that I've been hearing people say the last 2 weeks, round about December 10th, we're going to be in for a whole world of hurt. So I'm asking you, I'm pleading with you, use whatever spheres of influence you have to get this information into play in our community. Help our community be safe. Now is the time for us to step up and show advanced citizenship.
Thank you so much. So we have 1 minute left and 2 questions unanswered, and I'm going to see if we can get some answers to those before we log off. Are you considered high risk if you are healthy but over 65?
I'll take a stab at that, Ellie. I think back in the spring, the majority of patients that at least, I'll just speak to the local experience. The experience we had locally was that probably most of the patients we cared for on the hospitalized side were very elderly. And also, as we all know, our nursing home population was very affected. The patients that we have now are starting to be a little younger. There are folks in their 50s and 60s who are requiring hospitalization. So yes, we do consider folks over the age of 65 to be high risk, even if you do not have any other health problems. So unfortunately, age alone can be a risk factor.
Thank you, Cynthia. And one last question. Are we seeing cases of PTSD with our healthcare workers in this area, and how are we helping them?
So I can mention for this because I think there's one of the chaplains I know very well because I met them as I started, and I know like a lot of like the chaplains and palliative care have been really stepping up to make sure we're also protected from our own illnesses as well as PTSD, as well as from behavioral health. I think the flip side to that too is, as Paul mentions, as part of my plan, when I see patients, I also think of them because we've never had to do this before. So I do think there's reflections of also screening for depression and anxiety and PTSD, even from everyone that we're seeing within our own community.
I'll just add to that, and I'm gonna draw upon my past experience as a physician for the Department of Veterans Affairs. I took care of a number of patients who were corpsmen in the Army and who had post-traumatic stress syndrome, and what they saw was truly horrifying. I am pretty active on Twitter, and so I've been watching. I see a lot of stuff that's tweeted by a lot of physicians. I was watching very carefully the physicians from Italy during Lombardi, the physicians from New York City. While I think the healthcare personnel are not necessarily seeing the blood and gore that corpsmen were seeing, what they are being thrown into is situations of watching somebody dying with no visitation policy and seeing people die alone, being helpless to stop it. And these are all very similar themes to what the corpsmen in the Army described to me, just without the blood and gore.
That brings us to the end. I want to thank you all so very much for attending today's session. We hope we were able to answer all of your questions, but please feel free to email echo@psu.edu if you have additional questions we were unable to get to, and we can put that in our follow-up email to you with slides and a link to the recording of this session if you'd like to share it with your community. Thank you so much. Happy Thanksgiving.